medicine at the Peter Bent Brigham Hospital and Harvard Medical School. And I guess we brought him back because we didn't learn a lot about hypertension, but there is a lot to learn, actually. So he's a charter member of the American Society of Hypertension. So who better to teach us than Dr. Mende himself? Thank you.
Great pleasure to again participate in the symposium, and want to again thank Dr. Khan and Dr. Mufti for inviting me. I guess this is my third or fourth time. I think it's fourth. So I enjoyed coming here. The last time I brought my wife here and enjoyed all the parks and areas to visit. So let's get started with hypertension, because we have had several trials in the last year coming up, and many of the trials being reevaluated with meta-analysis and other analysis. I'm trying to get through many trials. I'll show you a lot of data, but be patient. At the end, I will hopefully streamline it all to give you a couple of numbers which are easy to remember and clearly apply to what should be done for the time being. My disclosure is basically has nothing to do with my presentation. To give you an overview, just what is still valid is that basically 1/3 of the U.S. population after age 21 has hypertension, meaning 140 over 90 or higher. It's a very nice number to remember. You turn 50, you have a 50% chance of hypertension, 75%, and age 90, 90%. So if you are obese and inactive, as we heard earlier today, these numbers will move earlier, so you can be hypertensive at age 20 if you're really obese. If you're looking at the goal, if you're taking your medications, about 2 out of 3 are controlled. I gave the British numbers in parentheses because you always compare it with socialized medicine. And like with the A1C or anything else, LDL and hypertension, we're actually better than anybody else I can think of, at least in my area of expertise. So these are basically the landscape. I'm not trying to insult you, but basically one of the most violated recommendations from JNC7, and that still holds today, is the not having a back support. So if you do take blood pressures in the office, sitting on the examining table and having your legs freely swinging and you have no back support, your systolic may be 6, 7, 8 or more millimeters higher than when you sit in the chair with back support. And that is probably at least one aspect of the so-called white coat syndrome. We'll talk about it in a moment. So one always should discard the first reading and if at all possible, do home blood pressure readings. So here's the question: what actually is the number of blood pressure readings taken at one visit, which is the best? And let's just go to all the recommendations. The bottom line is actually the nicest study from Kaiser, looking at literally 5,000-10,000 patients, and what they showed is that if you take it 3 times, throw the first one away, you average out 2 and 3. 1/3 of the patients who were above 140 as you started your visit turned out to be normotensive. So you basically eliminated 1/3 from being called hypertensive and or started on medications. So as we get into more home blood pressure readings, which probably should be done on anybody who can afford the $29 or $30 for a gadget at home, Omron, and buy it at Walmart or Costco, and I don't have any stock in either one of those 3 companies. So there is actually a better correlation to events. And like with anything else in medicine, we don't lower blood pressure because we like a number. We lower blood pressure because we like to reduce events. And something which is becoming more and more prevalent for reasons not so clear, and we don't know the mechanisms, are people who feel so cozy and comfortable in the office that their pressure is normal, but when they're outside the office, they're hypertensive, even when they're at home relaxed. So that is called masked hypertension, and because you're hypertensive most of the time, it shows as many side effects for events as somebody who's hypertensive 24 hours a day. In addition, like you know from our diabetics, if they follow their sugars, they may show up for the visits more and take their medications. Same is true for people with hypertension. If they take their pressure, let's say at least once a week or twice a month, they're more likely to take their medications. And again, we have 2 white coat issues. One is white coat syndrome, which is a patient who is hypertensive in the office and completely normotensive at home. This is actually more common postmenopausal in women than males, reasons unknown. But the more common aspect is the white coat phenomenon. That is a patient who is hypertensive on medications but has higher office pressures than home pressures. We don't worry about those people because they're on blood pressure medications and they're controlled at home. So this is that aspect. From a nephrology standpoint, if you have albuminuria, if your pressure gets higher, even without any change of renal function, your albuminuria gets worse because you're transmitting more pressure to the glomerulus and so you have more filtration pressure. So you have a correlation with that. And just to get the ultimate endorsement from the U.S. task force, which tells you when to do a PSA or not, and as you know, there's some questions about some of the recommendations, but they do recommend confirmation by home blood pressure. So because we have so many methods now to measure blood pressure, office with a regular gadget, then using automatic blood pressure measurements, observed or leaving the room unobserved, or doing ambulatory measurements at daytime, at night, on home blood pressure meetings, we now have 15 studies, as I tried to put them all together, to compare. And what is kind of really reassuring to me, because I'm a big fan of home blood pressure readings, is that the automatic office blood pressure reading observed with the technician or the physician stays in the office, and the daytime ambulatory blood pressure measurements and the home blood pressure measurements are actually pretty similar in number. They're within a couple of millimeters of each other. So this is actually particularly the FLAG study, the one from 2017, is the one who did these comparisons. Because we have gone away from hypertensive workups by essentially not looking at most people anymore. So, well, you got hypertension, you're 50 plus. It's you got hypertension, that's it. We do a very limited workup. We're beginning to miss more people who have what we call secondary hypertension. And the newer numbers show that 1 out of 6 usually has a secondary cause, and some of them are listed here. Obesity should be number 7. I'll get to this in a moment. But particularly if you're younger than 40, 45, it may be as many as 1 out of 3. And what we're particularly missing is aldosteronism primary, which could be an adenoma or bilateral hyperplasia. And particularly, we also miss sleep apnea. We should be talking to the significant others to get a good idea about sleep apnea. Just a quick aspect of aldosterone excess, or primary aldosterone, that 80% have a normal potassium, because we're always taught that if your potassium is low, that's the tip-off to do the test. So you're missing 4 out of 5. If you have somebody who has a lot of end organ damage, unexplained left ventricular hypertrophy, or without having a normal EGFR, and they already get microalbuminuria without obesity, or the pressure is 160 over 100 to start with, or you have difficulties getting their pressure down, or they have sleep apnea, these people you really should do an aldosterone test, and the best test to do, you do an albumin, usually an aldosterone renal ratio, and if it's over 10, 15, at least be suspicious, and you can collect some 24-hour urines or do other testing. So you got to keep the potassium back up to 4, and you got to make sure they're not dehydrated. And what happens if you have renal artery stenosis? Well, then your aldosterone level is very high and your renin level is very high. If you have aldosterone excess, the aldosterone is high, the renin is very low. So this is a good way to measure. And just, we forget about one of the best tests ever to be suspicious of renal artery stenosis. If somebody's EGFR is 70 and you give them an ACE inhibitor or an ARB, and they drop 25-30% from whatever level they are, that person has renal artery stenosis until proven otherwise. So this is really a very good screening test. And then we do renal ultrasounds, which are fine unless your BMI is 35, and then you probably need to do an MRI or CT to look at the kidney size. And also you can do a duplex flow study, which is important because you can measure intrarenal resistance, and that's just a simple test looking at systolic and diastolic blood pressure, and there's a formula to do that. But also don't allow the radiologist to tell you the kidneys are normal size. I want them to measure each size, because if it's 1.5 difference in size, that's suspicious. And I just tell you, I used to pick up 2-3 hypernephroma a year by doing ultrasound, presenting as initially the hypernephroma, renal cell carcinomas, as hypertension because the tumor was compressing the kidney, producing renin. And you make new diagnosis of polycystic kidney disease. You find people who had a stone silently blocking one kidney. So the renal ultrasound is under $100, and if you have hypertension with any suspicion of secondary causes, it's a really very cost-effective way to look at. So just quickly, what happens when you have sleep apnea, particularly 10, 12 episodes a night, you are hypoxic and hypercapnic, and so you stimulate your sympathetic nervous system. Studies show that your 24-hour excretion of metanephrine or norepinephrine is elevated. I mean, it's not as high as you get with the pheochromocytoma, but it's elevated. And at least half of them have hypertension, and at least 60-80% have obesity. The disappointing aspect in hypertension is that the average reduction of systolic is about 6, 7, 8 millimeters from CPAP. So it's not as effective as we thought it would be. However, it is important for the fatigue and for the patient's quality of life otherwise. So let's just now go in some analysis which all sprung up in the last year. So I give you from about 12 journals the reviews. If you look at the largest analysis, which is essentially 50-some years, and you just look at 120 trials, over 1,000 patients each trial. So what happens if you lower the systolic by 10 millimeter if you're above 140? So you're 150 and you go from 150 to 140, and these are the benefits, and these are usually typically benefits to be gotten for 5 years. So nobody really looks very often beyond that. I have a couple longer data, but that's 5 years. So as you can see, congestive heart failure is becoming more and more recognized, and is as high as CVA. We always thought that we're preventing strokes, but now we're really finding out that we're also preventing a lot of congestive heart failure events. So if you're on dialysis, 10 millimeters don't unfortunately make much of a difference whatsoever. And if you do have CKD, meaning your eGFR is less than 60 for most part, and or you have diabetes type 1 or type 2, your numbers, the benefits are very often half what a non-diabetic or what half what a patient with normal renal function has. And as you can see from all the studies, the bottom line was that if you just got below 130, that you did very well. So this is that study. And then somebody said, well, let's just look at the diabetics. And we have enough trials of those. And what do we get if you go below 140, if you're up by 10 millimeters? And as you can see, the numbers for CVA are the same for non-diabetic, but the overall cardiovascular mortality and morbidity was actually only reduced half as opposed to a non-diabetic. But then we have the microvascular events, which are the pathies in nephrology, retinopathy, neuropathy, and nephropathy. They were reduced even when you went from 140 to 130 or from 130 down to 120, while the other mortalities in CVA were not as impressively reduced. So we'll get to this other studies in a moment. So this is a study all cardiologists know because it was 20,000 some patients who had coronary artery disease, and they were treated with a beta blocker, which was atenolol, thiazide, and trondelopryl, which is a ACE inhibitor with rabamil, the calcium channel blocker. So after 2.7 years, they stopped the study, and I don't know why they stopped it so early, and there was a total wash between the two. But now we have many of the patients in the trials still seeing their physicians who were in the trials who got 12-year follow-ups. So that's pretty good. It's not double-blind anymore, but we still got 12-year follow-ups. And you can see that if your systolic was over 150, you had about a 40% higher all-cause mortality, which is mostly cardiovascular events. But if you did go in the people with coronary artery disease below 130, you also had a higher mortality. So this study said, well, if you have coronary artery disease, whether you're 40, 50, or 60, and nobody in that study was over 75, you're best off between 130 and 140. So I'm going to give you now, for various comorbidities, meta-analysis data, what the ideal blood pressure should be. For diabetes, for CKD, for people who had a prior stroke, for people who had coronary artery disease, because it will turn out to be, in some instances, a different number. And then there was this concern which goes on for decades in the cardiology literature, knowing that if you lower the diastolic below 70 or 60, you do get some increased cardiovascular events. Why? Because 85% of the circulation of the coronary arteries is in diastole. Anything else, basically in medicine, from the brain to the kidney to your toes, gets systolically perfused. But Mother Nature decided to have the heart diastolically perfused. So they actually could show in people who had an event, who had an MI for most part, but then were followed for 50 years. And by that time, they all were in their late 70s and early 80s. That for them, it was good to have a diastolic above 70. Again, these were people with coronary artery disease. So just quickly, a study which was published almost 10 years ago, again, was ACE diuretic versus ACE calcium channel blocker. And this study was very surprising. They all had the same pressure. Both groups had 140 over 85. And how they did this is remarkable in so many patients. But the calcium channel blocker, ACE inhibitor, had 20% fewer cardiovascular events, and also from a nephrology standpoint, had 20% less progression of loss of renal function. And this group had a large number of African Americans, which we know are difficult to treat. So this analysis last year, splitting the diabetics and the non-diabetics in that group, and said, okay, we all were down to 140, so let's see who has the best outcome with diabetes, and the best outcome was less than 140. But if you lower the pressure down to 120 to 130 in that diabetic group, you had the same outcome, okay? So if you lowered it below 120, you had more events, so you lost all the benefits. Then you look at the non-diabetics, they were best if you're just gotten below 120. So you already can see there is quite a bit of variation in response depending on what your comorbidity is. But also, again, very often, if you get down to 120, no matter who you are, you have a lower stroke incidence. So we'll address this in people who had a prior stroke. What should their number be in a moment? So here's the old OnTarget, which was again published many years ago, and a couple of weeks ago, somebody reanalyzed all of the data, and OnTarget was ramipril or telmisartan, so it was ACE inhibitor or A or B, and if you couldn't take an ACE because you coughed, they just gave you an A or B. So they look at this almost 31,000 patients, and they were on the average 55. They did have coronary artery disease, and only about 70%, 2 out of 3, had hypertension. But nevertheless, what was their number? The best outcome, around 130 over 75. If you got down to less than 120, or your diastolic was less than 70, or your systolic was above 140, you didn't do as well. So you can already see we're sort of fiddling around and getting around this number of 130 becoming an important number. And recently, another issue was what happens to somebody who doesn't have diabetes but has CKD, i.e. typically EGFR is below 40, below 60, so you have an EGFR of 45, 50, 55. And what do you do with this group? And as you can see, if you lower the pressure to this group below 130, there was no benefit. And then some of them, the EGFR got worse. And we all know this as from nephrology and cardiology, that in some patients with, let's see, a EGFR of 40 or 30, you lower the pressure down to 125, and the next thing you know, their creatinine goes up and the EGFR goes down. So these are the numbers for the non-diabetic CKD. Last week, this large study from China came out, and as you know, if you're Asian, whether you're Chinese or Japanese or Filipino, makes no difference, there is a much higher incidence of strokes for any given systolic hypertension as compared to African Americans even, or Caucasians. So the main concern in China with the high incidence of the high salt intake and still rather reasonable BMIs by U.S. standards is the disability and death rates from stroke. So here you got some 17,000+ patients. Average age was rather young, so to speak, of 60. but they had no other disease. They had no diabetes, no obesity, no CKD, no coronary artery disease, nothing. So they had only one endpoint. So they did almost a 5-year study saying how many strokes can we prevent and what is the best number for Chinese. And their ideal blood pressure number was 120 to 130. If you less than 120, they actually were 4.3 times worse. And the systolic above 130 for that group was also worse. So basically, they came up with 120 to 130 in that study. Okay. Here's the study I mentioned because we're always concerned if somebody had a CVA or had multiple subcortical or one small stroke or so-called microinfarcts, what should their blood pressure be? Should it be lower or should we allow them to have a higher pressure? And here are about 3,000 patients, 63 years old, followed for 3.5 years. And they said, well, is it better for somebody who had a stroke or TIA or small microinfarct to have a systolic less than 130, or are they better off between 130 and 140? And here's the numbers they had attained, 127 versus 138, and there was no difference. It was actually a surprise because most of us said, well, if you go below 130 in these patients, you may prevent more events. So basically, if you're somewhere around 130, in the group with prior CVAs or microinfarcts, you really will have the same benefits as being more aggressive. So that was that study. And now comes the most important study, which will change our guidelines and will make the numbers go down. It was the SPRINT trial. So these were patients who are 50 years old with cardiovascular risk factors, either having coronary artery disease or having a high score of 15% 10-year risk, or eGFRs below 60, or they were healthy in 75. Okay, but there were no diabetics, no people with polycystic kidney disease, and also you had to have an ejection fraction above 35, and no proteinuria above a gram. So basically, that was the group. So why didn't they use diabetics? Because you already have studies from ACCORD, so we knew the diabetic numbers. So they attained 125 versus 136. So this is what they got, and the study needed to be stopped early. So when you stop a study early, it's either very good or very bad. So this one was surprisingly good. So there's 15 millimeter differential. So here are the results. So look at the cardiovascular mortality reduction in less than 5 years. I mean, impressive, 42%. So if you look at MI, CVA, CHF, I mean, 25% reduction. And then again, CHF admissions, really impressive. 38% reduction. But if you had eGFRs of 50, 40, there was very little improvement with a lower pressure. And the same was true for some of the people with severe known coronary artery disease. So here is the really issue. The issue is you and I should not take the numbers from SPRINT and say, this is the number I'm going to attain in the office. Why? Because the way they took the blood pressure is that nobody does it like they did. They put the patient in a room, let him sit for 5 minutes, put the automatic gadget in there. The first reading was discarded. They waited 5 minutes for the second one, 5 minutes for the third one. I mean, it took them forever to get the pressure. And so if you look at these readings and you actually compare them to home blood pressure or ambulatory daytime pressure, you should have, the best number I can give you is at 10 millimeters. So if SPRINT said you should be at 120 in your regular office home, if you're 110, you're fine. 130, you're fine. So add 10 millimeters to this, and this is being discussed in hypertensive meetings, and we'll have the guidelines coming out between the ACC, American Cardiology, American Heart Association, and the ASH, the hypertensive group, in September in Chicago. So we'll get numbers, so it'll be interesting to see. So I showed this before, basically just to tell you that home blood pressure readings are very similar to the automatic office reading, but with somebody in the room. So there is still that component of attendance or no attendance. So when you think that you're getting more aggressive, particularly if you're 75, 80 years old, that you would have major problems with orthostatic hypotension, which means you drop your systolic within 2 minutes of standing more than 20 and the diastolic end or by 10, but they showed the opposite. So 3 times more people became hypertensive by raising their blood pressure by 20/10, and we have no explanation. The discussions in the journals totally avoid this. I mean, nobody talks about it, and be interesting to see how this evolves in the future. About how do you explain it, and what does it mean in patient care? So, people that very quickly said, okay, what happens if we lower our guidelines even from the 140 down to 130 for most of us? We would have about 100,000 fewer deaths using the enhanced data from the government. So they did a sub-study also on Sprint Mind because of our concerns about hypertension being a contributory to Alzheimer's, not just strokes and microvascular insults. I'll show you the data in a moment. So what they found is that a higher albumin screen, so if you had a urine albumin above 30, meaning you have microalbuminuria, or above 300, which means you have albuminuria, is actually parallels a cognitive decline. And as you may already know, microalbuminuria, even with normal renal function, is actually the best test we have for endothelial dysfunction, because you have endothelial dysfunction not just in the kidney, and you also have a system-wide coronary arteries in brain, etc. And you and I should be testing for microalbuminuria, not just our diabetics, which we do. We should be testing at least once a year or so when you see them, our hypertensives, for particular if their pressure is 160, stage 2 for microalbuminuria, all our obese patients. So we should be actually testing people with metabolic syndrome. We should be testing it more. So what it really showed, look at this, if you doubled in the span of this 4 years, if you went from 30 milligrams of microalbuminuria to 60, it was equal to 6 to 14 months of aging, and they did brain MRIs and memory studies. So it looks like that microalbuminuria or albuminuria, for reasons we have no understanding of at all, is actually declining once memory and it enhances cerebral aging, so to speak of. And this is a nice slide I tried to put together for the data, what hypertension risks are towards dementia, because it's becoming such a discussed issue, and the incidence, as we know, of Alzheimer's unfortunately is going up. So we always thought that strokes and microinfarcts are responsible for knocking out megabytes, so to speak of, in your brain computer. But we now know that even that the pressure, if it's uncontrolled, let's say 150, is actually increases your risk of Alzheimer's. Again, mechanisms not so clear. And you can see from the Honolulu Heart Study, which showed that ginkgo is totally useless, so stop taking it. It didn't show anything. And that's a 6-year study. But it showed that if you were uncontrolled, okay, now again, this is mostly an Asian population in Hawaii, that if your systolic was over 160, which you hopefully don't have any of your patients walk around who take the medicine, you had a 4.3 times, 4 times the risk of dementia. And here comes the good news. No matter what antihypertensive you choose, if you get below 140, you halve the risk. So that's very nice to know. And again, it showed that proteinuria was associated with much more increase in cognitive decline, even with normal renal function. Okay, a couple days ago, again, this is just popping up. I mean, the journals are just full with studies on hypertension. We're getting more interested in the older. So in this definition, it's 76. They were all Japanese, and their systolic was above 160. There was actually an old study on valsartan, which was nobody looked at anymore. But now we're trying to see, reanalyzing old data, what was the best blood pressure for these 76-year-old with systolic above 160, and the best number for that group was 130/45, looking at MIs, CVAs, CHF, cardiovascular outcomes. So this is the number for the Japanese Asian 76-year-olds, so 130/145. Okay, and also last month or 2 months ago, the Italians, who have, with their Mediterranean diet, I guess a whole bunch of 88-year-olds, they saw. And in Europe, when I was still in Europe, we had this rule in the 60s, 1960, that we're 70 years old, and they said, well, it's 100 plus age, you're fine, you're 170. So So in Italy, that must still be spooking around because they had a whole bunch of Italians with blood pressure of 160, 165, 170, and they said, Doc, if you reach my age, I will trust you that you can, and I'll take your blood pressure pills. So there was a whole group for half of them who declined to be treated, despite the fact they were hypertensive, 150, 160, 170. But the other group said, well, maybe I'll listen to my doctor. And look at this. In the span of 4 years, you had a 34% reduction of strokes and CHF again. But you didn't reduce the MIs in the 88-year-olds. So at that point, you either have coronary artery disease or you don't, but you can still beneficially affect congestive heart failure. And then they looked at younger groups in their clinic, and it's actually a pretty nice study. And that's a good journal, too, so it's actually reliable data. Okay, quickly, a couple words on resistant hypertension. You're not at goal at 140/90 using 3 drugs, which always is a diuretic, and a calcium channel blocker, an ACE, for most of us. So that's about 12% of the patients. If you look at them, why are they not controlled? A third of them don't take the pills. So they take 2 out of 3 pills, or they think they're very smart, they're taking all 3, but they're cutting them in half. So there are all kinds of mechanisms patients fool you with. Now, the Germans did a study where they have a lot of money, socialized medicine. Their taxes are 55% in Germany, and sales tax is 21%, so you can do a lot of stuff. They did spectrometric analysis when you came to the office. They looked for the drugs you take. It's probably a couple, $200, $300 for one test. And they said, lo and behold, half of the patients weren't taking any drugs. So no wonder they weren't controlled. But then they looked at all the studies of people who were not controlled, the ones who took their medicine, and they had a terribly low use of aldactone. And I think, I would say if I see somebody not controlled on 3 drugs, ACE or ARB, calcium channel blocker, and a diuretic, in their 150, 160, you just add low dose aldactone, or if you get breast tenderness in a male, eplerenone, and your pressure will go down 10, 15, 20 millimeters. I mean, that's the magic drug number 4 for most our patients. So if you look who's resistant in the frame of time, not surprising, obesity, diabetes, CKD, so what is one thing we find in all the people who are resistant? They usually have a more than generous salt intake. I'm talking about 10 to 12 grams. Ideally, it should be around 5 to 6 grams of salt. If you say, what's the difference between sodium and salt? You divide the salt by 2.5. So 6 grams of salt is 2,300 milligrams of sodium. And so 2.5 is the multiplier. If you look at the DASH diet or the Mediterranean diet, it clearly has double the amount of potassium and double the amount of magnesium in it. And we know potassium is Mother Nature's vasodilator. If you love salt, increase your potassium intake because you will have an increased urinary sodium excretion. And you can show from studies that about 50 MAQ of potassium lowers your systolic close to 5 millimeters. Okay, and if you don't have a good control, your pressure is 146 on thiazides, calcium channel blocker, and ARB. Don't add aldactone. Just stop the thiazides. Use 12.5 or so clothalidone, and you get another 5, 6 millimeters. So clothalidone is far more efficacious, and this is why this recent ARB Darby is I'm not advertising for it, but why is it more effective than the other ARBs? Because it's the only one which added clothalidone instead of thiazides to it. So if you add clothalidone to valsartan, you get much more bang for your buck. And something I need to tell you, because the cardiologists are the only ones who are paying attention to in hypertension, is patients' pulse rates. So if you sit here calmly and your thyroid function is normal, you don't have a panic attack, and your pulse is 80 and you're hypertensive, you need a beta blocker. So if you are obese or have metabolic syndrome and you give them atenolol, you're going to create 25% of conversion to diabetes in the first year. So what you should do is use a vasodilating beta blocker. They don't cause diabetes, they don't make you gain weight, they don't cause erectile dysfunction. And the 2 on the market is nebivolol and carvedilol. Okay, so very quickly, on obesity, let me just skip it. Just say the bottom line here: if you gain 1 kilo, your systolic goes up by 1 millimeter, whether you're normal weight or obese or morbidly obese. So basically, there is a wonderful relationship, and it's not just mechanical. if your BMI is over 30, from 25 to 35, in these 10 points of BMI, there's a linear relationship between the amount of aldosterone in the plasma and urine, because fat cells in the abdomen are giving a signal to the adrenals to make you release more aldosterone, and aldosterone, as we know, holds on the salt and water and raises your blood pressure. So if you're obese, you have a stimulation of the renal system, so your plasma renin goes up, aldosterone goes up, and also your sympathetic nervous system is stimulated. So what is the ideal drugs with obesity? Well, really not different. What we normally do is use RAS blockers, diuretics, and don't forget aldactone. Even in 12.5 every other day, if you have issues with potassium, the drug is very long acting, half-life is 72 hours, so this is a much neglected drug for many hypertensive, including obesity. And lastly, if you have sleep apnea, you usually have elevated aldosterone levels. And not only does aldactone help you to lower the systolic blood pressure, it also improves the severity of sleep apnea. So now we have data that aldactone is beneficial, even in 12.5 milligram doses, to two aspects of sleep apnea: the degree and severity of sleep apnea, as well as the blood pressure reduction. Okay, let's get to the heart of things. So what are the guidelines? They're actually about, almost 2 years out of sync, let's use that word, from the Heart Association, ACC, and ASH. So basically, these are the numbers they have. If you're over 80, less than 150 over 50 over 90. For most, all of us, less than 140 over 90. But if you had an MI or CVA or you're younger, they want you to be below 130. And again, the old, very easy to remember number. If you're 60, don't lower the diastolic below 60. So this is actually a good number. This is not my number. This is actually SSC, the ACC's. And here are guidelines from the Diabetic Association, updated this January. And their goal is less than 140 over 90. But if you can tolerate it, go less than 130 over 80. And again, the first drug on all diabetics should be ACE or A or B. And so you see their recommendation. And here's something which we all should pay a lot of attention to. In diabetes and in CKD, if you choose your ACE inhibitor at bedtime for 5 years, or you use the same dose for 5 years in the morning, there is a 12 to 14% lower incidence of events if you take it at bedtime. So I want to remind you that even if you don't have diabetes or CKD and you take an ACE or A or B or calcium channel blocker, what have you, maybe except for thiazides, because you usually take them in the morning if it's more than 12.5, you should take an HS, because if you look at the benefits reported on the HOPE trial, which was the first trial to establish all the benefits we talk about of ACE inhibitors, it was strictly, you had to use the drug HS. So if the HOPE trial did HS, so why are we not using HS? So bottom line, if you're on 4 drugs, you should probably take 2 in the morning, 2 in the evening. If you take a calcium channel blocker ACE or calcium channel blocker A or B, take it HS. And so you can distribute the drugs. But definitely, if you take an ACE alone or A or B alone, it should be HS. Okay? And just to confuse you, just the guidelines of the American College of Physicians, they came online in January. Let me just skip over them and give you my favorite number. There is a group in the world, Asians, Australia, Europe, and the US, we meet once a year for an International Society of Hypertension meeting, which I'm a member. And we looked at all these data, and I said, look, what is the one, you got to give sometimes somebody a number for just about anything, diabetes, CKD, 75 years old or so. So what should you do? And I think the number we came up with is pressure somewhere around 130. So this is like becoming the new golden number, which actually is 10 millimeters lower than what it was a year or 2 or 3 ago. And I think that's actually, some patients may be better off if they're 40 years old to be down to 120. That wasn't argued, but for the average hypertensive, no matter what other comorbidity you have, around 130 is probably a very good number to remember. So just to summarize it, for all the various other diseases, if diabetes, the best one from all the studies, I added all the meta-analysis I showed you today, I added them all up all the recommendations in it divided by the number of studies. Okay, this is how I got to this number. So this is my biased numbers. Diabetes, you're best off around 130. CKD, with or without diabetes, you're best off about 130. But you're worse off in some instances below 130. If you have no diabetes and you're younger, you're probably better off below 130. And if you're 85 or older, you should be definitely below 140 unless you can't tolerate it. And if you can stand up and you can tolerate it, you can try to go even a little lower, closer to 130 or so. Make sure your diastolic stays above 60. So I hope with all the studies I showed you, I didn't confuse you. So just remember around 130, if below 140 and maybe ideally closer to 130 for most of us is the ideal number. And we'll wait for the guidelines for all the agencies by the end of the year. Thank you very much.